friends. Dave Bjork here, lung cancer survivor, patient advocate, and research evangelist. And welcome to the Research Evangelist Podcast. And I'm coming to you, as always, from just outside of Boston. As you know, the Greek meaning of evangelist is bringing the good news. And I like to think that I'm bringing the good news, sharing stories about amazing people in lung cancer research and care who are doing amazing work. I call them brilliant but not famous. And of course, that's the funny part because they're well respected and well known in their communities and the people they serve, but they're not famous in the sense that my next door neighbor probably doesn't recognize their name. But I love sharing their stories and sharing the work that they're doing, and they really are amazing people. And I'm really excited today to have Dr. Mara Antonoff. And Mara is completed her undergraduate studies in chemistry and biology at the University of Pennsylvania, which is kind of interesting. Well, here's the interesting part, because we both are from Minnesota and we went to Penn, so I thought that was kind of cool. Then she earned her medical degree back at the University of Minnesota in Minneapolis Medical School, and then she completed her internship and residency in general surgery at the University of Minnesota, then a fellowship in cardiothoracic surgery at Washington University School of Medicine in St. Louis. And then she joined the faculty at MD Anderson in the Department of Thoracic and Cardiovascular Surgery in 2014, where she is today. And we'll learn more about her journey. But first of all, I'd just like to say welcome to the program.
Well, thank you so much. It's such a true privilege to be here to join you. Thank you so much for having me. I'm really excited about it.
Awesome. It's so great to see you. And it's been great to get to know you. We met at a advisory board, I believe in Texas, I think we were.
That's right. Yeah.
Yeah,
for me.
That's right, which is where you are now. But let's start by, I mentioned that you're from Minnesota and went to Penn, which I thought was really funny because we kind of went to Penn to get away, to get far away and explore a new part of the world and all that. Yeah. But let's start by having you just tell us about yourself.
Sure. So I grew up in a suburb outside of Minneapolis. I don't come from a family of physicians. My dad taught elementary school, second grade. I have an older brother who still lives in Minneapolis. My folks now live in Texas, like me. They came here, followed me. But I grew up with not a lot of exposure to medicine and not necessarily knowing that I wanted to become a doctor. That kind of came further down the line. But I guess my childhood was probably just a pretty simple one with lots of library books and lots of family time and kind of typical upper Midwestern upbringing. I grew up as a competitive figure skater, which wasn't so hard to come by living in Minneapolis. There were ice rinks everywhere, and the closest one was just about a mile from my house. And so that was a place where I found a lot of passion, a lot of opportunity to focus on something that was hard and something that I wanted to attempt to master. So I spent a lot of time on the ice, and I think probably not the typical story of most cardiothoracic surgeons, but that's where I spent my youth.
Well, and I think a lot of people, being a fellow Minnesotan, don't realize that a lot of the outdoor rinks, when you're little kids, they play hockey outdoors. Yeah. At least they did when I was a kid, and those at general parks around town, they'd have these ice rinks that people skate in. So yeah,
absolutely. So I had my skates that I could skate outside in, and then I had my figure skates, which were, couldn't destroy the blades by skating over like grass and, everything else. But yeah. And it's kind of funny because, you'd understand this also as a Minnesotan, but I live in Houston now and I have 4 children, but most of my boys play hockey and my older son to a pretty high competitive level, and certainly not a common thing for people in Texas. So, when they hear the boys play hockey, they're always surprised until I justify it with, well, I grew up in Minneapolis, so it makes sense.
Well, maybe someday they'll end up at University of Minnesota or Boston College playing big time hockey. Who knows?
That's right. Yep. You never know.
Yeah. Never know. You mentioned that you didn't have other family members in medicine, and that you didn't know early on. I know a lot of people that I talk to, they know when they're young, really young, that they might want to be a doctor. Yeah. But what was that? When did that strike you? Or when did that moment happen for you?
Yeah, it's kind of funny because I tend to be someone who is quite a planner, at least at this stage of my life. Everything is well planned, but this was 100% like a decision of whimsy. I was an undergrad at Penn, and the variety of reasons why I decided to graduate after 3 years, predominantly financial. And so I was spent the time that while I was at Penn, mostly studying and working, and I was ready to just move on and graduate and get on with the next phase of life. And I had chosen a chemistry major because I liked chemistry and I thought it was fun and I thought it was interesting. And I realized I had enough credits to get a biology major as well, but I had no idea what I was going to do with it, which is totally contrary to anybody who knows me at this stage of my life, that I didn't really have a plan of what I was going to do next. And at some point, I think, it was a little over a year into my undergrad education, I realized I was planning to graduate, after the third year, and I needed to come up with a pathway. And I realized that a lot of the other students who were in the chemistry major, which was a pretty small major, were either planning to go to grad school for chemistry or planning to apply to medical school. And I looked at some of the teaching assistants in our chemistry labs and realized they spent all day in the lab, doing chemical experiments, and that wasn't really the lifestyle for me. I was seeking something that was more interactive in a bigger setting, an opportunity to interact on a daily basis with a lot of people. And I mean, I kind of on a passing thought, decided, okay, well, maybe I'll just take the MCAT and apply to medical school, and figured it would be an opportunity to use the knowledge I'd acquired and to be able to interact with people. It definitely wasn't one of those folks who knew from a super young age, like, I want to operate in the chest, and here's all the reasons why. I think
Right.
No, I was really unprepared. And I think I was unprepared for I don't know, for every element of it. I didn't know what to expect in medical school. I didn't know what to expect out of a career in medicine, but I certainly don't regret a single thing about it. So I'm very, very happy things landed me kind of serendipitously where I am.
Yeah, and it's interesting. A school like Penn, for me, I was in the Wharton School, so everyone graduated. They're going to go get their MBA, or they're going to go,
Yeah.
be an investment banker. It was sort of like,
Yeah.
and I didn't do either of those. So it's kind of interesting how our paths kind of went a different direction than some of our classmates. But
yeah, for sure.
So when did you decide surgery was the area that you wanted to focus?
So once I started medical school, I was at a school that had a heavy emphasis on primary care, and I think they make one of their strongest goals of the University of Minnesota to give back to primary care for the community. And at the time, I thought, oh, maybe I'll be a pediatrician. I like kids, and I had this strong desire to help take care of people. And this is a shift at some point, and that we can talk about when we talk about lung cancer. But I had this idea that I wanted to take care of people who weren't responsible for their healthcare problems, who couldn't be held accountable for the situation that they were in. I love that idea about pediatrics. But I actually remember the first 2 years of medical school, my fellow students would tease me and always tell me, like, no, you're definitely going to become a surgeon. And I knew nothing about different specialties. I didn't know what kind of people applied to medical school, but they were like, no, you're definitely a surgeon personality. You know, the way you study, the grades you get, where you sit in the classroom, the speed at which you speak, you're meant to be a surgeon. And, they were totally right. Then you do these rotations in third and fourth year. And as soon as you're, exposed to a specialty, you realize either you fit or you don't. And definitely as soon as I had one day on a surgical rotation, I was like, oh, these are my people. This is how I spend my day. This is the kind of like instant gratification, technical skills based, impatient treatment that is best for me. So no, I realized very quickly once I had exposure to surgery that was where I belonged.
And it is a special person that becomes a surgeon. And of course, we know many of the same thoracic surgeons. I've had many of them on my show.
Yeah,
with very interesting backgrounds. But definitely, I can see where there's how people recognize that in you. That's kind of interesting that they say, "Oh, you're definitely going to be a surgeon," right? So,
yeah.
And then I always love to hear about mentors that I talk to in medicine. Has somebody they can point to, or multiple people they can point to. So, how was that experience for you? And who were some of the influencers in your path?
Yeah. So, I will say that it's been different at different stages. When I was a general surgery resident, I initially thought I wanted to be a pediatric surgeon because I had thought the same idea. I want to take care of people who aren't at fault for the disease they have. And I think it was once I started doing research and fell in love with oncology research. I was doing bench work and it was actually in a pancreatic cancer lab, because that was the lab that my chairman had, and was learning so much about oncology basic science and really fell in love with that as well. And I was working with heat shock protein inhibitors, and I'd sprinkle some of the drug we were working with on neuroblastoma because, again, I still thought I wanted to be a pediatric surgeon, but I also realized how much I loved teaching. And so I started doing a lot of surgical education research that happened to be coincidentally with our surgical education leadership at our institution who were thoracic surgeons. And so I did some research with them in surgical education. And so those mentors of mine were Mike Mattis and John DeCuna, and I worked with them very closely. And ultimately, I enjoyed working with them so much and started then sprinkling some of my heat shock protein inhibitor on lung cancer cells. The more I started working on some of the research in the lung cancer space, the more I realized that this idea I had in my head that I wanted to fight for people who perhaps, were children and couldn't have made different dietary choices or, behavioral choices to get themselves to where they were at, that I was totally wrong. I had a full 180, a full flip in perspective that I realized everyone deserves outstanding care. And I no longer had this idea like I wanted to help people who couldn't be blamed, because none of us should be blamed. No one should be blamed for any diagnosis, any medical condition. And in fact, it was more important to me to take care of patients who had diseases that I felt really drawn to from the physiology and pathophysiology and kind of just the disease process and the treatment itself. That was something I loved, but also folks who were maybe the underdog, who maybe weren't always the ones you'd expect to people to want to take care of or to look out for. And definitely there was a huge gap in care, in research, in compassion for lung cancer at that stage of my life. So I really got pulled into wanting to do something for lung cancer. And that's ultimately, how I ended up kind of shifting perspectives and saying, no, I think I want to be a thoracic surgeon because it's technically challenging. It's fun. It's exciting. I love the heart and lungs, but I can really do high level oncology research and make an impact in that space. And that was how I ended up, with the interest in thoracic and in thoracic oncology. And I think that once I went to Washington University for my fellowship, that's where I also met some really phenomenal mentors who truly shaped me. And I would be remiss not to mention Alec Patterson at WashU, because he was a huge influence for me. And I would say, it's interesting saying this about a man mentor and a man sponsor, but he probably, for the first time really made me feel like I didn't need to fit in as a woman surgeon in a man's field, but rather that I had something special and different to offer and that I could be proud of who I was. And rather than trying to be like everyone else, that maybe there was a place for me as I was in the world of thoracic surgery. And that was a different message that was also really important to me. So different mentors gave kind of different gifts along the way. But I think that part about self-identity was super important to me at that stage of my life as well.
That's really interesting. And because I've spoken with a lot of the women oncologists and surgeons that I've had on my show, talk about, and one of them mentioned the difference between mentorship and sponsorship, which I thought was really interesting. And, I had never thought of it, to be honest, but I really think the fact that man had such an influence. And I'd like to ask you, because I know we talked about this previously, about the underrepresentation of women in thoracic surgery and why it's important to you. I think it's important as well, but I'd love to hear your perspective on where we're at with that and why it's important to you.
Yeah, absolutely. Well, and I say some of this from my personal opinion, but some of it obviously comes wearing the hat, as I am currently the president of the Women in Thoracic Surgery, which is the largest organization of women cardiothoracic surgeons in the world. And I'm certainly familiar, based on the literature, based on our research, and based on my own lived experiences, of the challenges that women have in our field. Despite the fact that we have pretty much quantitative gender equivalence in medical school in the US at this point, which it wasn't when I was in medical school, but now it is. It's half women, half men. And even in general surgery residencies, which it wasn't as I was coming through, we were a much smaller group. We have, almost 50% of general surgery residents. We're finally to a point that women are about a quarter of cardiothoracic surgery fellows, yet the attrition rate for women is substantially greater than it is for men. And even people switching fields or dropping out after completing their training. We know that women are getting into the field less frequently with less support, less mentorship, less exposure, less opportunities. They get less operative autonomy. And this is not just my opinion. This is their data to show less operative autonomy through their surgical training. They're more often exposed to differential opportunities for research, for getting involved in career development strategies and job options. And then once they do enter the workforce, we know that they're paid about 75 to 78 cents on the dollar for what men are paid, ascend to higher levels of career, get leadership opportunities, speaking opportunities at lesser frequency than men. All of that is probably, those are things that people can tolerate. But then there's also the differential culture and the way that you're treated, and how at the end of the day, all we really want to do is take good care of our patients and give patients the opportunity to be treated by someone who maybe looks like them and represents them as well. It can be exhausting, but part of what makes it better is seeing change, seeing progress, having great sponsors and mentors and coaches and advocates and allies, and all of those things are really important. It's not just a numbers game. It's not just having someone who looks like you, but being able to ascend and make a difference and make an impact at the same rate. And I am super optimistic. I think we're at a phase where there is so much growth and there's so much opportunity. And while the women who are at the earlier stages of their career are exhausted from mentoring the younger women, we are building an increasing force. And I am very hopeful that we are giving the message to these young women that taking care of thoracic cancer patients and patients with diseases of the heart and lungs, it is fun, it's exciting, it's rewarding. They are not only wanted, but they're needed in this field, and we need to make a place for them, whether we like it or not. It's the right thing for our patients, and it's the right way to ensure that we're giving our patients the benefit of 100% of expertise and talent, not just 50%.
I totally agree, and I'm honored to have you on my show to represent and to have this conversation. And as you know, I've had other women thoracic surgeons on my show who are friends of yours, as well as men as well. But I think it's really important. I love the work that people like you are doing, people like Nargis Flores and others who women who are supporting each other. Right? It's exhausting, but you're making a difference because you're forming these coalitions with people across the country, and supporting one another and helping mentor, the next generation. Because that's one of the things I love about mentorship is like you don't just get mentored and then be off on your way. You give back right. You get the ladder down to pull up the next group and help them. And I know from my surgeon was Doug Matisa, which I'm sure you know the name. He's not practicing any longer, but he was a pioneer. I mean, he was a giant. He was a big guy. He was also a giant in the field. But I love the fact that I love seeing more women in medical oncology and also in surgery. So thank you for the efforts that you're doing, because I do agree with that. It's hugely important. Yeah. And by the way, my one of my boys is a nurse practitioner, and I think it's great that more men are getting involved with nursing, because I think that's pretty cool too. So
yeah, absolutely, fantastic.
So we talked about. I know you and I had talked previously about sort of your interest in this multidisciplinary evaluation of patients and why that's important. Can you talk to us a little bit about what that means and why?
Yeah, absolutely. I think even 10, definitely 15 years ago, we would often think about patients really with lung cancer as being put into these boxes based on stage, and then based on that box you go into, that's the provider that you see, and they're going to be the one in charge of your care. So if you're stage 1, you go to a surgeon, and you don't even get to hear about the option of radiation, or you might not hear about other, molecular profiling that might be critical to understanding, what your disease might mean. And if you're stage 4, you see a medical oncologist, and you never talk to a surgeon or radiation oncologist, and you don't talk about the options of what local consolidation might mean, or how people can work together for a hybrid approach to keep an effective systemic therapy working longer. Patients with stage 2 or stage 3, the type of treatment they would get really might depend on who they saw first. And it's just not giving our patients the best treatment possible I think that was true even of what we were doing 10 or 15 years ago. But now we're in an era where we understand cancer biology better than we've ever understood it before. We know how much we don't know, but we definitely know more than we did. And not only do we understand cancer biology, we're better able to interfere with it. And, if we want to get into a big philosophical question, cancer staging is really a surrogate. It's an anatomic measure as a surrogate of what the disease biology is. And as we get better at understanding disease biology through blood-based tests, through biomarkers, through molecular profiling, and as we get better at interfering with biology, with better and better drugs, better types of targeted radiation, using surgery in more aggressive situations, and most importantly, as we get better at working together and collaborating, that's when we really do the best for our patients. And ultimately, it's now to the point where patients with stage 1 through stage 4 have benefits that could be seen by seeing practitioners of every specialty. And there are situations where patients with stage 1 disease need everything, and there are situations where they need only one thing or two, and same thing for stage 4. And so we've seen so many patients do incredibly well with modalities we may not have provided for them in a historical context. And so as we're able to put our egos aside and remember that other people have toolboxes that may be different than ours, but if we put them all together, that's where we're able to really build, I guess, the best fighting chance of helping any individual patient succeed and hopefully get rid of their cancer, but if not, to create a joyous life with a high quality of life that turns something that may have otherwise been lethal into a chronic disease and a life that they are able to enjoy experiencing day in and day out. I think that's the most important thing. So long drawn out answer, which is typical for me, but I think ultimately,
it resonated with me, and I'll tell you why. I think from a patient perspective, being put in a box because you don't know what to do. I had someone recently, a friend of a friend, diagnosed with lung cancer. Was told that it was, probably stage 1, probably, it was sort of a community place that they were at that didn't specialize, didn't have a whole thoracic team. And we said, oh, you got to go see a surgeon. And she's like, so I talked to her and she's like, well, they don't take Mass Health, so I can't go there. That's a whole other issue. But she was being sent to a surgeon. And then she's like, well, maybe I could go see an oncologist. I mean, she literally didn't. That's, I think, to your point, the patient was being directed just to go see a surgeon, but wasn't being evaluated by other disciplines, which I think is really important. Like Mass General where I was treated, has a nodule clinic.
Yeah.
And so you have radiation oncologists, you have all these different people looking at, and as a patient, that's what I want. I want a whole team, not that I don't want to have a point person, but I want to have a whole team from different perspectives.
Right. And I think that's clear. Lung cancer has never been, but now more so than ever, it's not about one doctor making a decision or making a unilateral recommendation. That we know that the best outcomes happen when surgeons, medical oncologists, pulmonologists, radiation oncologists, diagnostic radiologists, pathologists, everyone, when they're all at the same table, but also all at the same table from the start. It's not trying one strategy and then saying, oh, that didn't work so well, now it's complicated, now what do we do? But rather having multidisciplinary care from the beginning. And, we've talked about some great institutions where you've been, where I've worked, where multidisciplinary care has been sometimes thought of as like a luxury, or this is for the elite. But really, it shouldn't be a luxury in lung cancer. It's really how we avoid missed opportunities and how we give patients the best chance at cure. And, we know that science is moving fast, but a lot of systems are moving slowly. And I think these multidisciplinary teams are really how we translate breakthroughs into real care differences for patients. And so fragmented care is not beneficial for anyone. And most importantly, not only is it detrimental to the relationships that care providers have with each other, but truly it's patients who pay the price when care is fragmented. And so we know that when it's coordinated, survival improves and quality of life improves and patient satisfaction improves. We're always happy to have patients wait while we wait for the result of a test, or wait for the result of staging, or spend time getting someone on the OR schedule, or whatever it may be. And they should wait. They should wait a reasonable amount of time so that we can do it right and do it right the first time. But one of those steps should be multidisciplinary engagement. It should never be unilateral. And sometimes it requires effort and coordination. But we, as a workforce, a big workforce of people, taking care of lung cancer patients, have been willing to put in the effort to coordinate things like molecular profiling and, lung function testing and all these other elements. We need to be willing to put in the time and the effort to ensure that multidisciplinary team engagement is present from the start.
Agree. And we can both agree 100% that everyone does deserve access to the type of care that I receive and the type of care that your institution gives. And I like the fact that a lot of the institutions like Mass General or Dana-Farber, or I'm sure MD Anderson as well, around here in the Boston area, if you're in like Southern New Hampshire, there's collaboration happening with the big Boston centers, which I think is really helpful to support those physicians and those clinicians in those areas as well. So, and I know you mentioned doing the research. I think it was during your fellowship or during your training, right? Tell us about any research that you're doing now that you're really excited about. I'd love to hear.
Yeah, I think in recent years, the research that I've been most talkative about are the trials that we've done in the space of local consolidation for patients with stage 4 disease. I think it's important for everyone to understand that the results are exciting. They're different than what we've presumed in the past, but it does not mean that a favorable result on any given study applies to every single patient. So I guess the first piece of advice I give to anyone is that when you're considering, some new or exciting trial, it's important to recognize, or a negative study for that matter, it's important to understand to whom it applies. But some of the most exciting data that we've seen of late, I would say, presented at ESMO in Berlin by one of my colleagues, Yasser Alamin, who's a medical oncologist with whom I work, presented our data from the North Star trial. And, we've had a lot of papers come out of MD Anderson in recent years talking about the use of local consolidative therapy. So local meaning, to the specific tumor itself, not a drug that's going through the whole body, but local treatment through the use of surgery, radiation to the primary tumor and as many sites of disease as possible for patients with stage 4 disease, to try to prolong survival, to try to keep effective drugs working longer, to try to delay time to development of new metastases. MD Anderson is a bit unique because these trials have been rather abundant in recent years, but we really continue to push surgery as one of the elements of local therapy. There are other places that are doing great studies with radiation alone, looking at the benefit of radiation. A lot of the studies we've been doing at MD Anderson have included adding surgery as an option as well. We've never compared those two head-to-head, surgery or radiation, but I think we are certainly at a point where it's clear that surgery should be a part of the discussion, because many patients need hybrid therapy. They may need some of both, and they may benefit from both. So the study that I mentioned that I was super excited about that Dr. Alamin presented in Berlin was the early results of our North Star trial, in which patients who had stage 4 disease and EGFR mutations were treated with osimertinib targeted therapy. And after a period of 6 to 12 weeks of osimertinib, if they had disease that had not progressed well on therapy, they were then randomized to continue on the drug therapy or to have local consolidation, meaning surgery or radiation to their primary tumor, as well as many sites as possible even if they had extensive disease, and then to go back onto the osimertinib or the Tagrisso. And ultimately, the result that was really important showed that progression-free survival was better for patients who received local therapy. And this is probably the first big trial to show an improvement in progression-free survival, even among patients who had what we call polymetastatic disease. So the definitions we use for our trials have relied on considering patients who have 1, 2, or 3 sites of disease to be what we call oligometastatic, or just a few sites, and poly, meaning many, to refer to patients with 4 or greater. And so what we saw in the data that Dr. Alamin presented was that the majority of the patients at the time of their enrollment on North Star actually were polymetastatic, and even at the time of randomization, the majority were still polymetastatic. We have not yet presented the surgical data. I'm looking forward to hopefully presenting it at the Society of Thoracic Surgeons meeting in New Orleans in January. But the surgical patients we know, without telling you the outcomes of those patients, I can tell you that the majority of them, an even greater percentage, were polymetastatic. And we just haven't seen much data out in the space looking at patients with polymetastatic disease. And so I think take-home points here from this study are that we can think about aggressive therapy in patients who have more extensive spread of disease. But also I think an important take-home is that we really need to start thinking about the biology of the disease and how it may differ from patient to patient, not just by stage alone. So for example, we have a parallel trial that we've recently completed. The data won't be ready to see for a few years, but the Lone Star trial was in patients who had stage 4 disease, oligometastatic and polymetastatic, receiving immunotherapy and no actionable driver mutations. And then they were randomized to local consolidation or to not have surgery and radiation. And the outcomes may be different. We need to be prepared to accept that we may see different results based on patients' genomic profiling, based on the types of drugs they're able to receive. And this is super important because it may be of more relevance in stage 4 disease to understand people's biology and their likelihood of benefiting from all the different modalities based on some of these profiling elements. So really tight investigations that focus on a specific patient group, I think are where we're going to see the biggest impact, so we can truly understand what's happening at a biologic level instead of just lumping patients into, okay, all stage 4 patients, what's the best treatment modality? This is where we get into personalized care that makes better outcomes for individual patients based on their disease.
That's awesome. That's so exciting. And thanks for sharing that. I think it's really interesting, from my perspective, of someone who had a lobectomy 25 years ago, to see the research that's happening today. It's on the shoulders of the ones that came before. So all the things that are happening today in lung cancer are because of things that happened 25 years ago, and you've been part of that, which is very exciting. So this is why I'm the research evangelist, because I believe that it's necessary, and it's the ecosystem needs people like you. We need the government. We need everybody. We're all in this together. I really believe that. So thank you for the work that you do. And the one last question I have for you, I have to ask everyone on my show, outside of work, tell us something that you're passionate about or people might not know about you.
There's so many things that I'm passionate about. But most people who know me at all know that I run a lot and that I love to eat a lot. But some people who don't know me well are often surprised to know that I am a mother of 4. They don't necessarily assume that about women surgeons. So I have 4 kids aged 8, 10, 16, and 18. They're probably the greatest contributions that I've made to this planet. I love lung cancer research. I love taking care of patients. But the main reason why I'm willing to spend so much time away from the people I love the most is in hopes that my patients can have more time with the people that they love the most. So I love cheering for the hockey games from the stands. I loved the year that I was a cheerleading coach for my daughter's cheerleading team. I like putting together Legos and doing family vacations. That's so much fun for me. And the amount of time I spend at the hospital and doing research and writing papers is not because I don't love those people. It's because I love them so much that I want very much to help other people have that kind of time with the people that they care about.
It's a beautiful sentiment. I really appreciate that. I really do. And I'm in awe of the work that people like you do, and many others. So thank you so much for all that you do for the community, the research, taking care of patients, having an amazing family, and everything that you do, and supporting women and all of it. It's been really great to have you on the show and get to know you. And thank you so much for being on the program.
Thank you so much. It truly is my privilege. Thank you. I really appreciate it.